All right, so we're going to get started here with our next presentation. I just wanted to quickly offer some clarification here on our forms. We are, please add WellSpect to the bottom of your form here, and Universal Compounding Pharmacy will be taken off. So again, add WellSpect, Universal Compounding Pharmacy will be taken off. So we'd like to welcome Dr. Jeffrey Alba. He's a board certified advanced practice urology clinical nurse specialist and sexuality counselor with over 30 years of experience. He currently serves veterans at Jesse Brown VA Medical Center in Chicago and has worked at top institutions like Northwestern Memorial, a respected researcher and author. His work focuses on sexual health and quality of life after prostate cancer. He has received multiple awards, including the SUNA President's Award and the Edward C. Capps Hope Award, for his contributions to urologic nursing and patient care. He has recently launched The Talk, Dr. Jeff Talks About Sex and Intimacy podcast every Tuesday at 7 p.m. Central Time. So please join me in giving a warm welcome to Dr. Alba.
Thank you so much. Appreciate that. And I'm excited to share my expertise. I'm so glad you're all here. I'm like, and I know I started this day. My wife's like, you guys, nurses start so early. It's like, really? And she's like, you guys are going to get there so early. It's like a work day. I had to get up. I had my clock set like I do when I go into the VA. I was like, wow. But it's great to be here and see so many familiar, wonderful faces and some new faces. So good to see you all. And thank you for being here and valuing the education that is presented. You know, the Chicago Metro Group, I remember when they started decades ago, and it's a lot of work. And so we really appreciate the hard work you did to get us these contact hours, to put this all together. So thank you, you guys. Excellent work. Vic has kind of made his life about helping, educating people. It's really amazing. We don't get paid anything for these podcasts. You do know that. It's like we don't make any money. We just spend our time and energy because we love it. They are labors of love. But Vic is like the man behind the curtain on The Wizard of Oz, you know? It's like he's back there making all this magic happen while I do the podcast. And so it's been really fun to do the podcast. But we have some wonderful guests on there. So if you get a chance, if you are a Facebook person, we would love for you to follow us on Facebook, because when we get 100 people following us, we can stream live there instead of just the recorded versions. But you can find us anywhere out there, and it's been a lot of fun. But you do amazing work. We all do. Stop and think about it. I know your clinic's busy and everything's nuts, and we're supposed to be creating more RVUs as advanced practice nurses, doing all these things, more for less, right? But we still get that amazing, miraculous moment when we sit down one-on-one with that patient and they share their most personal, private things with us. Who wants to talk about urinary incontinence, that they pee on themselves? Or who wants to talk about sexual dysfunction, or that they have vaginal dryness or erectile dysfunction? Nobody. So it's really challenging, but they walk in and they trust us with their most personal information. Stop and think about what an honor and privilege it is to be present with those patients. Remember how important, even when it's crazy and you're like, okay, I got so much to do. And this patient just told me for the first time they've ever told a person in their whole life that they were molested. This is going to be a very long visit, and I am not going to run on time the rest of the day today. I know that in the back of my mind, but I cannot dead stop in my tracks and be present with this patient. It is amazing work that we get to do every day. So don't forget about that. Why are we talking about that? Because we're going to talk about connectedness, and we're going to talk about that you should be dancing, the rhythm of intimacy. But intimacy doesn't have to be an intimate, loving sexual relationship. I had intimacy too with other people in my life. You do too. I had a deep meaningful relationship with my parents before they passed away, with my best friend, certainly with my wife as well. But you have people in your life that you have intimacy with. So we're going to talk about that because, and this is why I do the podcast, because this is like the greatest stuff in the world to talk about: love and intimacy and increasing that in your life. So without further ado, yes, you should be dancing, restoring the rhythm of intimacy, but do we need a dance partner anyway? And that dance partner doesn't have to be our lover always. That could be our friend sometimes. That could be our mother or father or sister or brother. That dance partner who you're dancing with too and having meaningful relationships doesn't have to be a sexual partner. You could decide, you know what? I'm done with sex. It's over and I don't care nothing about it. That shop is closed. That's okay. There's nothing wrong with that. I had a vet tell me recently, she said, I have come to the conclusion that I now am asexual. It took me a long time to accept that about myself, but that's okay. And I said, absolutely, that's okay. If that's where you are and that's where you want to be, that's okay. Sometimes that can be difficult if you have a sexual partner, though, right? Who's like, I'm not asexual. But she didn't have a sexual partner. And she was like, I'm okay with it. But it feels strange because that doesn't seem like it's acceptable and okay. But of course, that's acceptable and okay. But we, you and I, each of us, we are all hardwired. Hardwired. It's not negotiable for connection with other human beings, right? Is that true? Is that research based? Yes. You know, most of you are nurses, advanced practice nurses, PAs, right? What happens to babies when they do not bond with another human being? What do we call it? Failure to thrive. They die. They die because they did not bond with another human being. When we get involved in our lives and we put up the veils and the walls and all the things that happen, we don't start this way, but we end this way. And we think, I'm okay. I don't need anybody. I don't need anything because it hurts too much to need anybody or anything. But that is not true. We all need others. And if you want to learn more about it, you probably have heard about emotional intelligence, right? Have you heard the term emotional intelligence? Yes, everybody? So EQ or IQ. But the man who wrote the book on that, Daniel Goleman, who pulled together all that research, also wrote a book called Social Intelligence with all the research that says we are hardwired for connection with other human beings. Even as adults, even after we're older, we still have to have meaningful relationships in our life. Look at Viktor Frankl, who survived Auschwitz and the Holocaust, who hid things in his coats to try to keep his research alive about man's search for meaning. And meaning comes from connectedness. Connectedness is really important. So you're hardwired for it. The research says, gotta have it. Remember Maslow's hierarchy of needs from school, right? Remember those? Things like food, air, different things. But remember, there's also one down there, and it's not up there with self-actualization, which is a higher need, right? Love and belonging. Every human being needs a basic need of love and belonging. Often our patients are in our office because they're not feeling worthy and they're not feeling love and belonging. And so we got to remember how important that is, especially with our patients with sexual dysfunction and some of these issues we're going to talk about now. Vulnerability is really, really scary, right? It's very, very scary. What we seek and want most in the world is intimacy. Research actually showed what people want more than anything is intimate, meaningful relationships with others. But when Dr. Brene Brown looked at vulnerability, she said, what we are most afraid of is intimacy with others. So the very thing we crave, that we were born to, that we push towards, is the thing we're most afraid of. That's really important to remember because that's what sometimes causes a little bit of those hurdles that get in the way of this. And we have to break those hurdles down if we're really going to help our patients. Why am I showing you trees in Armstrong Woods? Because I just had an incredible opportunity because of Suna. I was at the advanced urologic meeting out in Sacramento, and then I went to Santa Rosa and to an area called Guernsville. And there's this amazing place called Armstrong Woods. And you see that Colonel Armstrong tree there, that one right there, that one, in that bottom picture is 1,400 years old. Look at the roots. This is a redwood. It's a type of sequoia, and these trees are amazing. These are amazing trees. But trees have a lot to teach us, and trees teach us that. Did you know that root systems are connected? Have you ever heard of a book called Finding the Mother Tree? Trees are intricately connected to each other, just like we are. They cannot survive, some of them, without each other. So they are intricately connected, and their roots, just like we are, intricately connected to each other and the world around us. Really important to remember when we're working with patients on intimacy. Okay, but here's the thing. We have couples. We have these patients who walk in our office, and I have been formally trained in couple therapy. I have gone through Gottman level 1 and 2 and completed all that. And then I trained for a year with Andrew Christensen in integrative behavioral couple therapy. Why? In the private sector, I always would tell patients, I don't do this. You can go see a counselor. But people are resistant. They're like, I don't want to go see somebody else and now have to tell my story all over again. So you have to deal with this even sometimes just on the most basic level. Because what would happen is we fix the erectile dysfunction. Wow, this is working well. This is going great. But our job is to fix the problems they came in for. And they're like, but we're still not having sex. But now you're having erections. Everything's going better, right? We fixed the problem. I gave you the prescription. It's all going good, right? We don't even talk to each other anymore. Okay, so if you're not speaking to each other, can you have intimacy? No way. We'll talk about what intimacy is in just a minute, but no, you can't. So that's really challenging. So that's why I learned I've got to work on this mind, body, spirit if I'm really going to help people improve their love play in their lives. So I got to work on it all. It's a big charge, but it's what we got to do. So in 2024, the divorce stat rates tell us that about 50% of first marriages and second marriages, even higher, 60 to 67%, end in a divorce. And here's the sad truth is many people who are together, and they walk in my office all the time, they're very unhappy. Think about what it's like to live with the love of your life who you no longer communicate with, but you live next to. You have a parallel life with them, but you really don't intersect on a meaningful way anymore because sometimes it becomes about just irritation and upset with each other and in the world, and you take it out on each other. So they come in and they're really upset with each other in a lot of ways. And most of the time when we come in, we're like, I'm here for couple therapy to show you how horrible things are for me. That's why I came in here, because I need someone to understand and acknowledge and believe that what I deal with here is horrible. Is that a good way to do couple therapy? No. And I came here before we get a divorce, so at least I know I tried couple therapy. So I say, first off, yes, sometimes we don't even get through the 3 intake visits to evaluate them, just like we do physical exams and everything. We delve into the relationship and pull it apart and examine it just like a physical exam. That takes 3 visits, including the feedback visit. Sometimes we get to feedback and they're like, yeah, this isn't working, but I tried it. And I tell them, no, you did not. And don't go tell anybody you did either, because you did not do couple therapy. You have to engage in couple therapy. Even if you show up in my office and you listen and you don't do the things we talk about, you did not do couple therapy. Unless you took it home, embraced it, and tried it, now you did couple therapy. So it's challenging, but it can be really rewarding. One of the residents follow me every Monday morning. They're like, oh my God, it is so intense. This couple therapy thing. It's like you have this person with their problems, this person with their problems, and the relationship, which is a big problem. I'm like, that is all true. That is all true. And believe it or not, my client is the relationship in love. It's not to side with this one or this one, to side with what brings love and positivity into the relationship. That's really who my client is when we do couple therapy. So we've established big problems. Most marriages or couple long-term relationships aren't necessarily happy and joyous and blissful. So what is the goal of couple therapy? Really to create more acceptance and adaptive relationship based on the realities of each person. and their realities can be really different. But the truth is one thing, and I'm right and you're wrong, right? There's not two realities. There's the reality, and it's mine, and you're wrong, right? But there can be two realities. Is that true? You better believe it. Okay, we're going to, and this is a great example that I like to use with my patients, and I used it once on the podcast, so you might see it on there too. We're going to Great America. Love Great America. We're going to go on the Demon. We're going to go on the Raging Bull, all these great roller coasters because I absolutely love them. I think they're the greatest thing in the world. They bring me high. It's the greatest thing in the world. It's like this, right? But my spouse says, have you seen me when I get off a roller coaster? I am literally green and want to throw up. Have you looked in my face and seen what it's like for me on a roller coaster? So we get off and it's like, that was so awesome. And your spouse is like, I need to throw up and I will never, right, Marianne? I will never go on that thing again. Do not ever drag me on there again. And I hate you for that. Right? Where's the truth? Whose reality is real? Absolutely. Both are always real. They're always real. So you got to look at both realities and convincing them that your reality is just as real as their reality. As desperately as you want them to understand you, they want you to understand them. When you're that desperate to understand them and that curious, couple therapy is going to rock your world. There's no doubt about it. But when you're so convinced, if you want to be absolutely right about everything and believe that your way is the only reality, we need to stop now because there's no point in couple therapy. We won't get anywhere because there are always two perceptions and two realities. And then, of course, we're trying to improve the relationship and overall life satisfaction. Oh my gosh, you two make each other miserable. This is no way to live. Look at you. Sometimes I let them start to fight. And I wish Maggie was here. She's like 2 doors down. She's like, oh my God, your clinic was like screaming, yelling craziness, And I'm just, and it's like, and I'm in the urology clinic. So they're like, I don't think, how when somebody's getting a catheter, like, oh, but this is like, I hate you. Blah, blah, blah. I mean, it is caustic sometimes, but I let them do a little of it sometimes because I learn a lot from the way they fight. And when they show me what it's like, and they don't totally show me the real knife that they cut with, right? Because they're being a little good because I'm in the room with them. So, but it's really interesting. You learn so much when they're fighting and also when they're working together and getting along. But it's fascinating work. So, evidence-based treatments for couples. First, we have non-behavioral things. Behavioral just means we're teaching you behaviors that help you, how to communicate different, how to behave different to make things different. But Sue Johnson came up with emotional-based, where we look at what are the emotions that are coming up? Why are they coming up? What are they about? How do we understand them better for each person and how they're affecting the relationship? Insight, aha moments. Wow, I never knew that I had never had any idea when I touch you this way, it triggers you because you were molested at 5 years old and someone touched your arm in that way. I never understood that, but now I do. So that's insight-focused couple therapy. And then behavioral approaches. There's traditional behavioral couple therapy, cognitive behavioral, and then mine, which I learned, integrated behavioral couple therapy. And so I'm going to tell you a little bit about those things. But let's start with Gottman, because I use both. I use the best of both worlds. John and Julie Gottman created a clinic where they watched over 3,000 patients for over 30 years. And they watched people when they were getting along, when they were not getting along. They had cameras in places. They did amazing research to find out what works and what doesn't work with couples. And they came up with this house. They said that the foundation of your loving relationship house, and probably any relationship house, is friendship. If that friendship's not there, the house will not stand. It has to be a friendship. You have to have a solid foundation of friendship. And that foundation of friendship is built on things like love maps. And you're like, what are love maps? They're things that help you move together towards each other more. Like questions like, do you know if your partner were to tell us what is their favorite blah, 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 what is that? What is your partner's dream now for the rest of their life? Maybe you knew what it was when you first met, but what is it now? Creating love maps, bringing them together around meaningful, loving relationships. How many of you have been in the restaurant? Are couples talking to each other? What are they doing? Show me. They're on their phones. Isn't it astounding? You look, they got the champagne sitting next to them, everything, and they're on their phones. They're on their screens, and we're on our screens all the time anyway. Put the blasted thing down. But that's not meaningful play. That's not meaningful love. And I say play because play is really important. Fun play. So building love maps, shared fondness and admiration. Ultimately, when my wife does something that upsets me, I know that fundamentally she is an amazing, beautiful soul. And she made a choice that I'm not real happy about and we need to talk about. I make lots of choices. She would enumerate the things I do wrong, and I teach people how to be in a good relationship. And my wife could tell you all the things I mess up all the time. So we've been married 39 years in April. So it's like she could lay them all out for you. So, but creating that fondness, that belief that fundamentally I'm not going to go after her character because she's a beautiful soul, but I do want to talk to you about the fact that blah, 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 blah. Okay. And then turning towards each other instead of turning away. And what they're doing when they're on their phones in the restaurant is turning away. That's not a positive bid. When your partner says something to you, and what Gottman looked at is, do you look in their direction? Do you respond to them? Or do you go on doing what you're doing? My wife's always like, this is not a multitask moment. Stop multitasking. You do not multitask when you're with me. And it's like, okay, that's true. And so turning towards that person, and then that overall positive perspective that I believe this relationship is worth fighting for. In fact, Gottman has a bank account kind of thing. And they say, build up the positivity, your bank account so high that when you have a withdrawal, which you will always have, a negative event, you'll have conflict. You will never agree on everything, that you don't go bankrupt. So what kills a relationship is not meanness, negativity, and all that. That's not helpful. But what kills a relationship is lack of positivity. There's nothing to fight for here anymore. I don't feel like there's anything positive left in this relationship. That's what Gottman discovered through his research. So, okay, the walls of the house are trust. You have to have trust in a relationship. And when trust is destroyed because of infidelity or whatever happened, it very slowly has to be built back. And it is a relationship killer if it's not. Trust and commitment. You can't be saying, and if you don't, I'm out of here. Next time I'm out of here. That doesn't work. If you don't, it is completely unacceptable and I will not tolerate it. And we'll keep working on it. Not, I'm out of here. That doesn't work well in a relationship. So commitment and trust. And when you hear people who are having trouble, they're dangling divorce over each other's heads all the time, right? And they're like, I don't trust you. I don't think you have my back. So those are problems. That's the walls. And then the managing conflict, because there always will be conflict. So managing that conflict, understanding that conflict, working on that conflict. That's really important. How do you talk to each other when you're in conflict? Because you know what it's like. When our back gets up, we're like, I cannot believe you, whatever, right? Whatever it is. And you want to go for it, right? And you know your partner well, so you know where to put the knife and you know how to twist it just right. But you don't want to do that because you love this person. So we teach people how to communicate, especially using Gottman has some great techniques, using eye language, all kinds of things that I can talk further about. We could talk about this all day, but I have to move on to the rest of the stuff. And then the highest level is creating big shock, meaning, shared meaning. I want meaning in my life. I want more meaning in my life. Really important, and sharing in that meaning. You don't have to be like my wife doesn't. She supports me because every Tuesday, Vic and I, our wives support us because we're together, Vic and I, every Tuesday at 7:00. That's for sure. And my guest, we're all together. And I got lights and microphones, and he's in his little den with his. It's cool to see it here because he does all that from his house in his studio. But that's where we are. And my wife has to be like, okay, I'm going to go to Costco while you do that. So I'm just out of the way. And, I'm like, okay, she loves to shop. I'm like, go do your shopping therapy. It's all good, And so it works, right? But she has to support it, even though she's not like, this is my dream. I want to do a podcast with you. You guys almost go further because you really live the dream too, right, Jody? You really live the dream with Vic for sure. But my wife's very supportive, but she doesn't have to participate in the dream itself with me. But we have to share the meaning that comes with it, right? Integrative behavioral couple therapy from Andrew Christensen, and you can see my references for all this too. This is all evidence-based stuff. It's based on building acceptance. It's that curiosity and that need to desperately understand the person I love, that I said I love with all my heart and soul. Who are they? Why do they do the things they do? Why do they function in the ways they do? Why is neatness not their jam? Why do they not care if they drop things around the house and I care greatly about it? And why do I care so much about the things be in order and be the way I believe they should be, the right way, right? And there's the wrong way. Understanding that. And both values could be equally important, right? We can't have the house a total chaotic mess, so that's an important value. But letting things go and not sweating the small stuff is an important value too. Now, dropping your underwear on the floor where I have to step on it to get out of the bed is not cool, okay? But both values are important. So again, we're trying to see both realities and understand them better. And so we do that through things like effective change, which is empathetic joining. Wow, this is why your partner's the way they are. It's not an excuse for the behavior that you didn't like, but this is why they function the way they do. They drop their drawers there. They do the different things they do because of this. It's like an aha moment. And now we can go, I get it. I get you. Who doesn't want to be got better? Who doesn't want people who, friends, family, lovers, who really understand us, who really get us, especially because life's going to bring us some hard things. You're going to lose, parents are going to die, siblings may die, children may die, people are going to get sick. You're going to struggle through, jobs will get crazy. The VA will send you a thing that says your job is not secure, even though you've been here 18 years. Don't count on it. It is what it is. The only thing I can do anything about is how do I receive it and what do I do about it? But it helps to have people who understand and get us. So it can be really important. So acceptance is about understanding and accepting the other person. Change is about, I can only be the change that I want to be. I can't change Vic. I can't change Joe. I can't change another person on the face of the earth, but I can sure change me. And my wife and I think why our marriage is successful, I will be dead honest with you, is because when we walk away, I always think, yes, it made me mad that she did this, but then I did that and that was not good. And then I did that. And in the end, I think I am, ugh, and I see the wrongness in what I did too. And she sees. So when we come back together, usually it's like, it's my fault. And she's like, it's my fault. And I think that's a great place of reconciliation to come from, because I can only change me. It takes so much work in couple therapy to get people on that, because they spend a lot of time doing this. And look at the rest of your fingers. When one finger's pointed, they're all pointed back at me. And all I can do anything about is me, not them. So it's challenging. Cognitive change is just, we have a problem. Can we work on problem solving and what we're going to do to fix it, just like we do at work or anywhere else? That's what cognitive change is. Effective change is understanding, getting each other. Cognitive change, behavioral changes, and what are you going to do to change it? How are you going to behave now? But it feels uncomfortable, Dr. Alba, when I say, I feel hurt when you took the check off my desk and I didn't know where it was, and I need you to leave my stuff on my desk alone. I want to say, I cannot believe you took that check. That's just like you always do. You didn't take your medication today, did you? I don't think so. Your mom used to do this stuff too, by the way, right? And you always do this. Always. You take my stuff. You do this. That's where people want to go, but it's not effective. So learn, and I say, you've done that. You've been there and done it. Einstein says the definition of insanity. What is it? Doing the same thing over and over and expecting different results. Can you try the tools that I'm giving you? Can you work with what I'm giving you? Because I can't do it for you. And that's how they change the relationship from the inside out. And it's amazing. It's amazing. Sex and intimacy. Sex is intrinsic, but it's multidimensional. Some of it's learned. Everybody in here would probably have a different definition of it, but we know what sex is. And when we talk about having sex, we're talking about the act of any genital stimulation for pleasure. Everyone's is different in what they need and want. Intimacy is the process by which two people attempt to move towards communication on all levels. That's intimacy is, you see me. You know me. You really know me. You understand me and you don't judge me. That's intimacy. And I don't know about you, but I'll take a whole lot more of that in my life. Everybody wants more of that. So that's a good thing. That's intimacy. And we all crave it and want it, but we're scared to death of it because then we have to really show up and be present. Sexual dysfunction is just that impairment in the regular pattern of that couple's sexual interest, response, and function. Their persistent impairment of a couple's normal and usual patterns of sexual response or interest or any of that. The sexual response cycle was defined by Masters and Johnson. They did an awesome work. They watch people have sex. They watch people masturbate. You could never do this research now because you'd never get it through an IRB. It's never going to happen. My research is flagged all the time because it's about sex, and all I do is ask questions. I'm not having anybody have sex in front of me or anything like that, but you could never do what they did. And there were some things that happened that weren't so cool, but amazing things came out of their research. And they came up with this linear model. It starts with excitement. It builds and builds to plateau where it's like, oh, it feels so good. It's so fabulous. It's so great. Let's hang out here for a while. And then orgasm, resolution. Somebody turns over and goes to sleep. It's all good, right? Whatever. But look at, we got a problem here though. Average time for males, average time for females. Anybody see a problem there? 4 times longer. These are generalizations, but that's why I tell men all the time who are partnered with females, I say, your penis doesn't go anywhere or get any fun until she's already close or on the brink of orgasm, because it's not going to line up any other way, probably in general. So, and 2, the clitoris and the penis, if you look them on Google Images, I love Google Images. It's like, get that image of them side by side and you'll be like, they are almost identical. If she ignored your penis completely and was trying to get you excited, help you have an orgasm, all that stuff, but she went everywhere but there, how would it be? That's what it's like for her when you ignore her clitoris. So really, really important things to help them. These are insights. That is that insight-based couple therapy that we do sometimes where they go, now some people are like, yes, of course. And some people are like, really? So those are the things that we try to remember when we're doing this. It's a linear model. It starts with excitement and desire and all that stuff, and it builds, right? And then we get to plateau. It feels really good. Hang out there for a while. People love to hang out and plateau. And then orgasm. The second line is the woman. Oh, I can orgasm a couple times. Keep going. It's good. And then resolution. Okay. But Rosemary Bassan, when she went to do her research, researcher's nightmare, by the way, full disclosure, researcher's nightmare for Rosemary Bassan, because over a third of the women in her study said she took the Masters and Johnson's model, which starts with desire and excitement. And the women said, no, doesn't. I don't know who you're talking about, but for me, it doesn't start with, I'm not horny when it starts. That's not how it starts for me. I actually need something different. And so she came up with this amazing model that I think applies for many men and women, especially as you get older and hormones are decreasing and things like that. These women taught her that it starts with emotional engagement. And I have a vet who he stays home with the kids, and I have male men and men partners, women and women partners. And some of the partners say, yes, it starts with emotional engagement. If we're not engaged, I really don't want anything to do with you. This isn't you go out and meet somebody, have sex. This is a relationship where you need to be emotionally engaged. And I'm pissed off at him. So I'm not emotionally engaged and I don't want to have sex. And for me, it doesn't work. Men and women both, some of them fall into this category. That motivates a sexually neutral woman to be a little stimulated, start kissing and touching and aroused. And then way over on the other side, we have sexual arousal and desire falls into place. I think that's really important for us to remember, because there's that immediate horny, I need sex. And then there's that we build into it and it becomes from emotional engagement. And more commonly, we find that that becomes important for a lot of people. So this model, I think, is really helpful when we look at sexual dysfunction. We have hypoactive sexual desire dysfunction, which is the like low libido kind of thing. Now, it could be a hormone-driven thing with testosterone. And by the way, women start with 1/10 of testosterone, men do, and then they go through menopause, which is nothing good for your sex life comes out of menopause. Your vagina shrinks, dries, and your testosterone drops from 10%, a tenth of what men have. So when someone just told me on the phone yesterday, I feel like a foreigner in my own body. I have no desire. I have none of this is there for her, because this is what happened with menopause. And we're not taught this. We don't understand this, but it's the reality. Some people come in and they're like, we're not having sex. And they'll give me a diagnosis from the other doctor of low libido, but it's wrong. Because they're like, I think about sex all the time. I masturbate 6 times a week. You have a libido for sure. Why aren't you having sex? Well, that's a whole different game because now I have to interact, I have to connect, I have to be vulnerable with my partner. And that's a whole different thing. So, all these things come out when we're working with the patients. Then, an arousal disorder like erectile dysfunction or becoming lubricated, all the things the vagina widens, lubricates to accept whatever's penetrating from a partner, a finger, a vibrator, a penis, a tongue, or whatever is going to be penetrating the vagina. Remember, the vulva is everything outside, the vagina is the canal. Orgasmic dysfunction, difficulty reaching orgasm. It can be primary, I've never reached an orgasm, or it can be secondary, it happened after I had my hysterectomy, or whatever. Pain disorders, it hurts when I have sex. Dyspareunia is I put a tampon in, I put anything in the vagina, it hurts. Genital urinary syndrome of menopause. If you live long enough as a woman, you're probably going to experience vaginal dryness or difficulties during sex. It's very, very common. Vulvodynia, where the vulva area hurts. Vaginismus, where you have spasms. Lots of things to think about. Erectile dysfunction. So when men and women walk in, I'm going to zero in on the things that are most often happen in my clinic, and then I'm going to answer whatever questions you have, and we'll talk about what you want to know because I work with men and women with all these problems day in and day out. This is what I do in my clinic. But the number one thing they come in my clinic and Ron's clinics for is erectile dysfunction. Right, Ron? Number one thing that brings them in is I can't keep an erection. I can't. That's a lot of times the first thing is I get it, but then it goes away. I don't even get it. That's the number one thing that brings them into the clinic. The number one thing that brings women is it hurts when I have sex. Even though desire disorders and libido disorders are the most common disorders in men and women, it doesn't always bring them in the clinic. Because remember, when you don't have a libido, it takes away some of your motivation. So you may not come seek help for that necessarily. And it may not be a problem for you or your partner. But pain during sex is a problem for women, and that's what brings them in. So we need to expand our thinking. If you, Dr. Susan Kellogg-Spatt and I just did a podcast Tuesday night on outer course and exploring the world of non-penetrative sex. And actually, we like to call it love play because penetration implies there's someone penetrating and there's like a dichotomy or something where one is higher than the other. So we like to think of it as just everything but insertion into whatever, insertion into rectum, into vagina, whatever. And so sometimes it's called non-penetrative sex. Awesome podcast. It was a lot of fun. Actually, there were no slides or anything, but I thought it worked really well. We talked about a lot of different things, and it was really great. And Susan Kellogg is just, I love her to death. She's awesome. But all right, there's many, many ways to have pleasure. Manual stimulation of genitals, vibratory stimulation of genitals, oral stimulation of genitals, rubbing genitals together, many, many ways to get there. But we're taught, but it all leads to penetration. Who learned the bases? Anybody? First, second, third, fourth. Come on, people. You learned the bases. Really? You all learned the bases. The final base is penetration, right? But that's our society setting us up to believe something. That's not the only way to pleasure. It's just one way. You don't have to be hard to have an orgasm. Men who have erectile dysfunction realize that all the time because it's usually a blood flow issue more than a nervous conduction issue. So they orgasm fine, but they have trouble with erections. A woman doesn't need a hard penis to climax or have pleasure or orgasms either. You only need to be hard enough for penetrative sex when you're having penetrative sex. Everything else is on the table. When she's like, nothing goes in there anymore because it just hurts and nothing's working to fix that. So that shop's closed. It's not happening anymore. You can still have amazing sex a bunch of other ways. She can hold her thighs together and the penis can move him back and forth across the clitoris with lubricant right there where it feels good for her and him. We can teach all kinds of great things to do. So that's really important to broaden their thinking, blow up their mind with non-penetrative sex. It's pretty fun and it's pretty mind-blowing. What are their goals? What do they want to do when they come into my clinic? Nothing else matters. What that doctor said to you, what anybody thinks doesn't matter. What do you want? And what do you want? And I always like partners to be there because if they can both be there, they can both say for themselves what they want and need. Now we're going to base our whole treatment plan on what you both want. Sometimes we take intercourse off the table to remove the pressure and everything else of it. And I'll talk more about a little bit of what we do with that. But anyway, so if sex, we're not trying to make babies at this point. It's for pleasure and connectedness. And she's like, oh my gosh, I get so nervous because I know he used the vacuum pump and there's things that are expected of me and my blood pressure is going through the ceiling. This is not fun. Okay. You are not making my homework fun. We are not drilling your teeth. You are working on pleasure and fun. Make it fun. Don't forget it's fun. It's called love play. It's supposed to be fun. If it was fun and you felt deeply connected, you can tick the box. You had intimacy and you did it. If you had a meal at that Ethiopian restaurant where you use your hands and you were feeding each other and all the people are like, "Ew, get a room," right? You had intimacy. And they're all thinking, "Dang. Wow, whatever." If they didn't get arrested, it's all good and they had intimacy. Okay? So the bottom line is, what do they want? Sometimes a good cuddle can be worth its weight in gold. Just to really cuddle, bottle to spoon, whatever. So we teach them and we work on these things with the goals of connectedness and pleasure. Then communication. If we have never communicated about sex, we don't know how to, because here's the extent of our vocabulary. Oh, God, yes. Their name, maybe, whatever. Hopefully their name and not someone else's name, right? Yeah, get that one right for sure. But bottom line, I had one. She screamed out her ex-husband's name. I'm like, yeah, we got to work through that. That is real trauma for real. So communication's really important, and we have to teach them. We don't do that while we're having sex. We're like, can you stop? Because this is all wrong. It needs to be outside the bedroom. I love you. I love being pleasured by you, but I want to talk to you about a couple really important things for me. And that's how you have those conversations. And we teach them how to do that. So then for erectile dysfunction, we have oral agents. We have sildenafil, vardenafil, tadalafil. By the way, we don't have Levitra anymore because the company's abandoned that, but vardenafil generic is still available. Not sure if you knew that, but that's true. And then there's Avanafil as well. All these drugs, my job is not to hand you this and say, okay, this is going to help. It's to say, how are you going to integrate this into your love play with your partner? How are you guys going to do this? And how will it work for you? Because you're not going to be successful unless I help you think about that and work on that. Because now I have to time the pill. I have to figure out this. All of them have things. Because what the patient really wanted from me who had erectile dysfunction is, I think it's there. No more to it, the way it's always happened for me. That's what I want you to give me. I fail from the minute they walk in my door because I can't give you that. But when I give you these things, I have to figure out how we can still make it work in your love play. So I have to work on a lot of little nuances, and I can talk about for days any of this about oral agents or anything else you have questions about. But timing is a big thing with them. Side effects, different things. We have to look at it all. But the great thing is millions of people have tried them. They're pretty safe. Even for cardiovascular patients who aren't on nitrates and different things, we have lots of cardiovascular patients who take them and use them safely. They work for about 70% of patients, but they have some side effects. Nothing's perfect. So we have to look at them and figure out how we're going to help them use this. This is the vacuum pump. I did a whole podcast on it, tips on how to be successful because it's tricky, it's cumbersome, it can be messy, but it works in 90% or more of patients. I've literally known 2 patients that when we worked on it together, we couldn't get it to work out of 1,000, a good 1,000. So it works for most patients. It's got all kinds of issues and it's not for everybody, but it works. It's physics. It forces blood in the penis and then we trap it with a ring. So we gave them all our great hints to be successful with it because it works and it's non-invasive and you can use it along with the pills. Nothing's perfect. And I don't try to talk people into anything. I tell them the good, bad, and ugly so they can make their own informed decisions with the vacuum pump, with the pills, with the shots, with the surgery. I never push them towards any treatment. I say, here's the good, bad, and ugly. What do you want to do? How do you want to integrate it into your love play? I'll help you do that. Injections. I've wrote many articles on it. They used to call me the injection king because I wrote so many different papers. I did a study on it that it doesn't hurt, that the patient ratings are like a 1 out of 10 on the pain scale, and 40% said it didn't hurt. Lots of things with injections. I'm happy to answer your questions, but you are the key to success for these treatments for sure. This one, they need to be doing in their clinic in front of you with you teaching them. And the other one, the vacuum device, and don't be afraid to have them bring in the vacuum device and work with you with it, because that is amazingly helpful. But at least teach them every little piece of it with a vacuum in front of them. Like Kay does in our clinic at North Shore that I used to work at, and Ron does. This is what we do. We teach them how to use it. And when it's not working, you bring yours back in and we'll work on it more. Women, remember, have pain, vaginal dryness, different things like that. So we follow the clinical guidelines. The ring, the tablet, the cream, they all work equally well. But bottom line is that area, vulva and vagina, crave estrogen. And when women go through perimenopause and menopause or on hormonal birth control, it is lacking, and it becomes, I've heard people say it feels like a knife going in the vagina rather than a penis. That's how painful it can be. So dryness, shrinkage, this is how we treat it. This is the standard way, even safe for people with breast cancer and hormone dependent cancers, because it's a local therapy, but I always get it cleared through their oncologist before I proceed with it if they've had a hormone driven female cancer. There's a variety of non-hormonal things, and I listed them here for you. Lots of good things. Remember, oils don't go in the vagina. They go on the vulva. Oils to destroy that natural flora in the vagina, so we don't want it up in there. But we can use silicone and water-based lubricants. We can use things like hyaluronic acid, which sounds horrible because it says the word acid in it, but it actually brings water forward into the vagina. And there's a lot of different products out there that have it, and it can be very helpful. New Eve was developed by an Asian gynecologist, and it can be used. So there are options. So I just want you to know, and I'm happy to answer questions about it. When they have a desire disorder, we want to rule out underlying causes, psychotherapy, psych referrals for different things. But remember, there's always one. Once you've had erectile dysfunction, you're in your mind, when you go to have sex, that man is thinking, oh God, is it going to happen again? It's so embarrassing. She's going to be upset. I don't want to disappoint her. That's anxiety. Anxiety is adrenaline. It's part of fight or flight. It's going to kill their erection. So we have to teach them mindfulness. Redirect your mind back to sex, sex, sex. What turns you on? It's warm. It's whatever it is, get it going in here, or anchor to what's happening down there. But don't go to, is it, what's it? Or worst case scenario, horrible is, oh no, I'm going to lose it. Okay. Simmering is what we do. That's kissing, hugging, cuddling. And then also besides simmering, you can do simmering together, but you can also think about sexual things that turn you on, and you can journal about them. Bibliotherapy is reading sexual things. I like it better. Porn can be very destructive to relationships. Some people it helps, but a lot of people don't like it because now you're seeing unrealistic things. Remember, the movie world is fantasy. Most people's penises don't look like or act like that, right? They don't. Porn is porn. It is what it is. And so now we're held up to that. Some people don't like that. But books, you have in your mind whatever it is you want to think about that. And so, and you don't even have to pay for erotica. It's in the library. It's called the romantic section. So just, it's very cheap to read bibliotherapy. Sensate focuses Masters and Johnson. I can explain that more to you, but it's about 49 minutes and I want to leave time for questions. So I'm moving through the rest a little bit quickly just because I want to leave some time, because we could talk forever about this. And I want to see what you want to ask me questions about. North Shore has a library of videos. Believe it or not, there's been tens of thousands of hits on those videos that I made, and they are there. But now that's sort of why Vic and I did this podcast, because now I don't work at North Shore. So the podcasts are enduring things that people can look at in the privacy of their home in the future. And that's drjeffsextalk.com. If you could follow us on Facebook, it would be so awesome, please. I don't even do Facebook, but I do have a Facebook Dr. Jeff account through Vic. And so, but if you follow us, thank you, because we do need followers to be live. drjeffalbaugh.com is where you can get this book for free. Your patients can download the new edition of Reclaiming Sex and Intimacy After Prostate Cancer. I get no money out of this book. I never have. All the money went back into developing the second and then someday the third edition. I'm going to give this to Katie so that then when you do the raffle, this could be not a great, it's not like $250, but somebody can win that too. And you can put it in your clinic and show patients and tell them, go on drjeffalbaugh.com and they can download it free. That's because my patients donated all this money to help other patients. My patients are so freaking amazing and brave. They are the reason I can do that, and why Kay can still hand that out in the clinic, because they gave money to do that. I like Sexual Health Matters from Sexual Medicine Society. It can be really helpful too. So those are some resources. But bottom line is, it took a lot of guts to walk in that clinic with you. It took a whole lot of guts to walk in that clinic and tell you their story. They do not want to share this with anybody. They don't want to talk about, it's just like my sister was saying, maybe too much information, but my sister was saying, I don't want to stick that applicator in there. I love that. She goes, it's like a pencil dick, and I don't like sticking it in there. I don't like that estradiol. And I'm like, I'm sorry. I didn't prescribe it for her, by the way, but her doctor did. But I did tell her about it. But I get it. They don't want to have to deal with this. It's so hard, but they're so brave to even walk through the door in your clinic. Be present with them, honor them. It's a wonderful thing. I'm going to take a couple of your questions, and then Vic knows I always end with a little centering exercise. If you hate it, then go on and do your Candy Crush on your phone or whatever. But I will do a little centering exercise with you as we finish. But I will take a question or two, because I think I still have a few minutes for that. Do you have questions about, this is your big chance, male sexual dysfunction, female sexual dysfunction, couples, anything and everything? Happy to answer your questions. What questions do you have? Burning questions? Yes. Thank you, brave soul.
Find how in your shoulders. I feel like some people internalize stress and it's in the pelvic area. Related things going, like I've had patients with hernia in different areas, and the wife's, blaming herself, different things like that.
Mm-hmm.
Whether it's gone back to earlier if they had like a traumatic.
Yes.
But I do find that people internalize stress in the pelvic area.
So the question is about putting stress in your body. Okay, how many of you guys have stress in your shoulders? Do you have stress? Do you when you get a massage, you're like, oh God, and if they push really hard, you're like, you're killing me. The body always tells a story. There's a book written about that too, about how that happens. And the pelvic floor is another place it loves to go. We're doing so many different podcasts on the pelvic floor. And I swear, I'm sorry about the infomercial on the podcast, but the guests are amazing and they're so cool. We're doing one on yoga and the pelvic floor that was designed for men after prostate cancer surgery. And she's going to teach all these so many cool things come out of the podcast. So, but we've done some great ones. Dr. D. Hartman, who's a pelvic floor physical therapist, was on and went into that in good detail. And how you store it there. We all do. And believe it or not, there's a great link between we store it in our jaw and our pelvic floor. If you guys, when you had babies and stuff, ladies, do you remember how they were like, relax your jaw too when you're relaxing down there? Because there's a link between that. But we store that tension in our body, in our shoulders, in our jaw, in our pelvic floor. What it does in our pelvic floor is what? It makes us go, oh my God, is he ever going to shut up? I got to pee so bad, right? You're sitting here listening and you're like, I got to go. Or it hurts when something goes in there. The number one reason for pain, dyspareunia, is hormonal. The number two is muscular, and usually it's both, because now it hurt. And think about it. Once it hurts, you're going to tense. So now you got both. So pelvic floor physical therapy can be amazingly helpful. You're going to really like my closing exercise, because we're going to relax all that stuff in a minute. And thank you for that great intro into my closing exercise. Anything else you want to ask me? And if you're afraid, I'll be here till 1. You can ask me personally, but anybody else have a burning question that you would like me to address about pills, shots, vacuum pumps, vaginal lubricant? What's the difference between a moisturizer and a lubricant? Whatever. Okay, well, let's get to the exercise then. All right, are you ready? Get comfortable. Get yourself comfortable. Find a comfortable position. Rest your hands wherever they're comfortable, either on the desk in front of you or at your sides. You figure that out. If you're comfortable, close your eyes as you do this exercise. And you're going to start a breathing pattern, counting 4 in. And when you breathe, open your eyes for 1 second. You're not going to breathe this way, because this creates more tension. You're going to breathe this way. and fill up from the abdomen. So when you breathe in, you actually center into it and open up this way. So if you put your arms here, you should feel yourself expand this way, not this way. 4 counts in, 4 counts out. And we're going to start. Breathe in and exhale. Breathing is so powerful. Continue that pattern. Breathe in and exhale. Keep going with that pattern. And as you do those breaths, feel yourself pulling all the incredible energy of these amazing caregiver, wonderful people in the room with you in as you inhale. And when you exhale, feel everything that doesn't serve you today. Feel it melt away. Where do you feel the tension? Do you feel it in your head, in your neck, in your shoulders, in your back? Wiggle it away a little bit as you exhale. Every breath gives you a chance to melt into the chair further as you exhale and release everything that doesn't serve you today. Inhale in. Bring that energy in and exhale. Slowly let it all go. Everything that doesn't matter, anything and everything. As you continue to breathe, keep in mind, I am enough. I am inherently enough. I don't have to hustle to prove to anybody anything because I was created as enough. I am deeply and intricately connected to the people around me, to these amazing, amazing caregivers that I sit with here today. I am deeply connected to those around me. My intention is to bring more love and kindness into the world because I want more of that myself, and the world needs more of it. I release. I have every right to feel upset and tense about some things, but I let it go because I do not want it to live in my body any longer. Every time I exhale, I release and melt away all that negativity, stress, anything that doesn't serve. And when I inhale, I pull in the new, fresh air and positivity around me. As I go forward through my day, I think about my intention and what I want. Say the words to yourself. What is it you want? What do you want this day to be about? All we have is now. Don't worry about yesterday. Don't worry about tomorrow. Now, what do you want? You can put it into a simple sentence. I want to be love and kindness in the world. I want to be John Travolta from Staying Alive. I don't know what you want to be, but you do. Lay out your intention. As you continue to breathe, and when you're ready, breathing's so powerful. Open your eyes to the new world around you. Thank you.